Welcome to the final conference of River EU. We are so delighted to have you with us, even though we're a bit sad that this 5-year collaboration is coming to an end. But still, thank you for coming to Brussels, and we do apologize for the weather, but unfortunately it's outside our control. And also we're very grateful for the online audience that we have are joining us online. My name is Essa-hadad. I'm a Policy and Practice Officer at EuroHealthNet, and I've had the pleasure to be part of River EU's team for the past 2.5 years. And today, me and my colleague, Alison, will be guiding you through the sessions. Alison?
Yeah, thank you very much, and good morning to everyone. It's really a delight to have you with us. Thanks so much for making the time, and we're really excited to have this opportunity to talk to you about River EU and to share our collective interest in all of this work around reducing vaccine inequalities. My name is Alison Masson, and I'm a program manager at EuroHealthNet. If you don't know EuroHealthNet, we are a Brussels-based partnership. We work with national public health institutes, local and regional authorities, and our work is all about reducing health inequalities within and between European countries, and that would, of course, include vaccine inequalities. And it has been a real privilege over the last 5 years to lead River EU's communication and exploitation activities, and it's a privilege to be co-chair of this conference today. We're delighted, as Afsana has said, to have so many of you joining us from all over Europe and so many people joining online. I hope that the connection's working well. And I want to also take the opportunity to mention that we are recording today's session. For those, May is always a very busy conference season, so many people said they would have liked to join and could not. So we are happy to have a recording that we'll make available later on. So, River EU, reducing inequalities in vaccine uptake in the European region by engaging underserved communities. When we started 5 years ago, we asked a deceptively simple question. Why do some communities in Europe remain unprotected by vaccines that are safe, effective, and free? And today we'd like to share with you what it is that we found and, much more importantly, what we actually did about it. So making vaccine equity work, community-led solutions for a healthier and more resilient Europe. That title is not aspirational. It is actually a description of what the researchers, practitioners, community members, and others in this room have been actively building together over the last 5 years, and how we've made this objective that we all share of vaccine equity into something that's operational. So our goal today is to make sure that it doesn't actually stop here, that we continue to build on these communities and this solidarity that we've been working in. And that's why we're really thrilled to have a fantastic lineup of speakers, including so many of you who are here. We hope that by the end of today, you will leave with the following 3 things. You'll have a better idea of how you can operationalize vaccine equity. You will see how our findings can be relevant to your work. What are the resources that we offer that you can apply to your day-to-day activities? And we hope that you'll also have some inspiration and ideas for how we can continue to work in solidarity around the topic of vaccine equity. So finally, of course, we're honored to be co-hosting in this space with the European Economic and Social Committee, and we really thank our colleagues here for their support and for their commitment. And it is my opportunity now to introduce Alain Coeur, who is a member of the European Economic and Social Committee, EESC for short. He's Director of European and International Affairs of the National Union of Socialist Mutuality Societies, and, as I said, a member of the EESC, where he's co-spokesperson of the EESC Social Economy category and president of the EESC Study Group on Social Economy Enterprises. So, Alain, thank you so much for being with us, and we'd love it if you could tell us a bit more about the connection between EESC and these types of activities and your interests in this work.
Thank you, Alison. Thank you very much for inviting me today. When we the first talk 3 months ago, when you talk about your project, I immediately say, yes, of course, I will be part of your final discussion today, because I have also a medical background, so for me it's very, very interesting to be part of your discussion today. Not all the day, unfortunately, because there is also a lot of work today in this committee. So for me it's a great honor to welcome you here and to host this conference, this final conference on the River EU project. For people who don't know the ESC, we're representing here employers, workers, and a broad spectrum of civil society organizations. The ESC has consistently championed health equity, solidarity, and social justice. We are not a legislative body, but we serve as a vital bridge between the European institution, member states and citizens. Through our opinion, because we produce a lot of opinion, more or less 200 opinion every year, we ensure that the lived realities of patients, and not only patients, of course, all the citizens, but healthcare professionals, mutual organizations, social actors, and communities are heard and reflected in the European policy making. In the recent years, the ESC has actively contributed to major initiatives, including the European Health Union and the EU Global Health Strategy. Europe Beating Cancer Plan, cardiovascular health, mental health, health work, challenges, prevention, and the resilience of health system. Today, all these trends converge on one fundamental truth: health system cannot be resilient if they are not equitable. This is why your project was so important. And from the crisis, COVID crisis, this crisis forced Europe into emergency mode. Today, we are rightly shifting toward a proactive prevention agenda. We see this in the European Health Union, European Beating Cancer, the growing focus on cardiovascular disease, mental health, health inequality as sustainable people-centered care. Vaccination is the perfect illustration of this shift. This is one of the most effective, cost-efficient and equitable public health interventions are developed. As RIVER-EU clearly demonstrate, improving vaccine equity inquiry much more than isolated awareness movements. Public health initiative and thematic campaign can play an important role in bringing prevention higher onto the political and public agenda. The RIVER-EU also demonstrates significant disparities persist. Minority ethnic and religious groups, Roma and traveller communities, migrant, refugees, and other underserved populations continue to experience lower vaccination coverage, not primarily due to hesitancy, but because of structural barriers. Limited access, language difficulties, lack of coordination, culturally inappropriate communication, administrative obstacles are eroded trust. They are not merely technical issues, they are social determinants of health. Addressing them is essential to building healthier, fairer and more resilient societies. One of the most powerful lessons of RIVER-EU is that health systems work best when communities are not passive recipients, but active partners. The project Participatory Action Research, working with community rather than for them, offers a model for the future of European public health. The concrete achievements are inspiring. Roma health mediator in Slovakia, community health promoter in Greece and the Netherlands, Ukrainian peer educator in Poland, multilingual materials, school-based approaches, navigation support and telecommunication. These are not nice-to-have initiatives. These are core components of the resilient health system. They align perfectly with European priority, integrated care, strong primary health care, neighborhood-based prevention, healthy aging and equitable local public health ecosystem. They are also full support the WHO European Immunization Agenda 2013. The role of mutual health organization, because I'm from a mutual health organization in Belgium, I represent Solidaris. Mutual health organizations are not only reimbursement bodies. They are trust social health actors, deeply rooted in communities. Through their dense association networks, health promotion cells, local campaign, and direct citizen engagement, they reconnect health system with everyday realities. Solidaris has constantly promoted vaccination as both a personal protection and an act of solidarity, including for the youngest children. Dear colleague, in today's geopolitical context, marked by climate change, population aging, migration, economic pressure, health work shortage, and the permanent risk of new pandemic, look what's happened in Africa with Ebola, vaccine equity is a strategic imperative for Europe. It's a matter of health security. Inequities anywhere create vulnerabilities everywhere. It's a matter of global partnership and leadership. Europe must lead by example, both internally and its international partnership. It's a matter of economic and social cohesion. Protecting every segment of society strengthens our single market and our social model. This also means supporting greater transparency and accessibility in scientific research and public health knowledge. In this regard, the open access approach of RiverEU is extremely valuable, helping ensure that evidence, tools and lessons learned can be shared broadly and contribute to vaccine equity and a genuine public good. In a context where inequalities in access to innovation and knowledge persist globally, promoting open science, equitable data sharing and international cooperation remain essential worldwide. Prevention is not a cost. It's one of the smartest investments to make in social cohesion, economic sustainability, democratic stability, and international solidarity. RiverEU has delivered far more than research. It has given us practical experience, community knowledge, actionable recommendation, and a concrete guidelines and action framework developed with ECDC and WHO Europe. The ESC stands ready to support the next phase implementation. We will continue advocating for stronger prevention-oriented policies, community-led and participatory approach, full integration of civil society actors, including mutual organizations, sustained investment in health promotion and health literacy, and equity as a guiding principle across all Europe health policies. Let us show that the lesson from RiverEU becomes part of the permanent architecture of Europe Health Union, because vaccine equity is not only a public health objective, it's a question of dignity, social justice, solidarity, and ultimately of the kind of Europe we want to build together. Thank you very much.
Thank you, Alan. I think your words really capture the essence of RiverEU, that it's about health systems, not individuals. And for that, we need community members to be active partners, not passive recipients. Thank you so much. And before we go anywhere else, we want to start the day with the results out in front. So RiverEU's team coordinator at the University Medical Center Groningen, UMCG, will take us through what the project set out to do and what it delivered. So we have here Janine Dezieux with us. I'm sorry if I slaughtered your name with my pronunciation. She is RiverEU's project manager and researcher at UMCG. She works on uptake and access to prevention and health systems responsiveness with a focus on interdisciplinary approaches to address equity, particularly for underserved communities. Janine, the floor is yours. Thank you.
Thank you, Afsana, for giving me the floor and for introducing me. I'm very delighted to introduce to you, on behalf of our project team, of course, the RiverEU project and also some of the main results that we have been able to achieve over the past years. So just a very short introduction on what is RiverEU. So RiverEU is a Horizon 2020 funded project, and in 2021 we started with our project, and well, we feel also very delighted today, but also a little sad that our project will officially end this year. As was mentioned already, within the project we adopted a health systems approach, and we started with the identification of health system barriers in relation to HPV vaccination and also to MMR vaccination among underserved communities across Europe. And what was also already mentioned is that the underpinning method in our project was really the participatory action approach, where we collaborated through the different phases with a number of different stakeholders, including the community members. So as you can see on the map, we have been working in different countries, and we had the so-called empowering example, so the countries colored pink And in these countries, we also identified health system enablers among the different communities. And in the yellow-colored countries, we have been working with underserved minority populations, and we've identified the health system barriers. And in these countries, the so-called implementation countries, we have been doing the main bulk of the work. And these communities are the Ukrainian refugee and migrant community in Poland, the marginalized Roma community in Slovakia, the migrant and refugee community in Greece, and also the Turkish and Moroccan community in the Netherlands. And as you can see, within the countries, we focused either on HPV vaccination solely or on both HPV and MMR. So just in a nutshell, our overall process, as I mentioned, we started with the identification of the health system barriers. Thereafter, we conducted transferability analysis to select the interventions we aim to implement and also to see what needed to be adapted. Thereafter, we started with the implementation and the monitoring and evaluation of the interventions in the intervention countries. And based on all the work done, we have developed the guidelines and also the educational output. So on this slide, you'll see the top 5 health system barriers as identified by the different stakeholders in the implementation countries. And as you can see, that despite the different countries, despite the different communities, the delivery of information is really a barrier that is identified as a top barrier. And this is also the barrier that we build upon in the rest of the project. So in parallel, we conducted a review of potentially suitable evidence-based interventions. And in the implementation countries, the participants selected the intervention that we thought would be suitable to be implemented. And this intervention used trained health promoters from the target communities. And so basically, this is what we did in the implementation countries. So from the different target communities, health promoters were recruited and also trained, and they gave educational sessions to the community members. And also through this participatory transferability analysis, the intervention was adapted based on the needs of the health promoters and also the community members, to really ensure that the intervention was fitted to the particular needs of the community. So on this slide, you'll see some of the main results. So we measured knowledge before and after the educational session across the 4 different countries. And for all countries, you'll see that the knowledge concerning the respective vaccination increased. So when looking at intention to vaccinate as a proxy for vaccine uptake, you'll see also in the 4 different countries that the intention to vaccinate increased after the educational session was delivered by the health promoter in all 4 countries. So we learned a lot through the whole project, and that's what's mentioned already, in collaboration with the community, with the health promoters, with relevant stakeholders. But I think there are some really key lessons learned for practice and policy that we would like to share with you. So the community health workers from underserved communities are really the single most important enabler. It's trust, language, and cultural credibility that cannot be replaced by information campaigns alone. The participatory design is an investment. It's taking a lot of time, but it really pays off because community co-creation with community members and health promoters produces interventions that community community members actually also use. We see that the educational interventions can address knowledge, attitudes, and intention, but structural barriers such as registries, documentation, but also access require a system-level reform. And trust requires about 6 to 12 months of relationship building before significant engagement is possible. So project timelines really must reflect this. And vaccination equity is achievable when interventions are grounded in trust, led by communities and designed with genuine cultural responsiveness. I would like to thank you, and of course I'm presenting the results, but this is really a collaborative effort of the RivRU project and all of our consortium members. Thank you.
Thank you, Janine. Thank you so much for your words. I just want to say that I know we're a bit behind schedule because we were waiting for people to be able to get in, but we don't want to rush the upcoming session as it is too important for us. So we're going to be going for coffee a bit later. I'm sorry. But so we just heard from Janine about the results and the evidence of what changed, and it was quite heartwarming to see that vaccine literacy and intention to vaccine uptake had increased across all implementation sites. But now with this upcoming session, we'd like to ground the day in lived experience of community members and those who were closest to the interventions. And I'm delighted for this session to hand over to Dr. Jumanah Essa-hadad. She's a research associate at Bar-Ilan University Faculty of Medicine in the Department of Population Health in the Gavrili. She was a lead researcher in the RivRU project looking at vaccination enablers and barriers among Arab minority in Israel. She has considerable experience working with civil society organizations at grassroots level to promote public health programs. Jumanah, please, the floor is yours.
On Voices from the Field. It's very exciting because I was really involved in the very early stages of this research and of the project when we were still identifying health system barriers and enablers to vaccination. So this session really does open up a very important part of the conference and sets the tone for everything that follows. Its role is to ground the day in human reality before the researchers, guideline authors, and policymakers really take over to discuss how we can move forward. The panelists in this session were actually living the interventions, hosting them, and navigating them from the inside. What they bring is what it is really like to do these activities and have the conversations with the communities and with the specific people that they were working with. So it is really an honor to introduce our panelists. First, I'd like to invite Mufida Nazri to the stage. Mufida is a certified psychiatric specialist and a second-year medical student. She is from the healthcare professional. She's a healthcare professional based in Poland, and she currently serves as head of the clinic at the Centrum Medyk and leads the medical training center for foreigners.
Thank you. Thank you, everyone.
She has extensive experience in clinical management, rehabilitation, patient care, and public health initiatives. And Mufida was the main coordinator of educational meetings on HPV and MMR vaccinations within the RivRU initiative, promoting preventative healthcare awareness and community education. She is committed to advancing multidisciplinary healthcare and medical education, and she is multilingual. She speaks 6 languages, and we all know that this is very important. It's very important to support effective communication when we're working with diverse clinical populations. Our second panelist is Ms. Daphne Gavrili. Daphne, if I can invite you up. She is the head teacher of the Intercultural High School of Athens for 10 years, and she holds a master's degree in decision science and is a certified teacher trainer. She has been involved in environmental education as environmental manager at the Central Sector of Athens, and she organizes many STEM workshops for teachers, and she's a dedicated educator with over 30 years of experience fostering inclusive, equitable learning environments. Our third panelist is Mr. František Turták. I'm sorry if I misread your name. Mr. Turták is coordinator of Roma Health Mediators within the Healthy Regions Initiative in Slovakia. And he is in daily contact with community members and collaborates closely with local primary care providers. He brings insights from multiple communities through his coordination role, and he was fully involved with River EU's intervention in Slovakia. And I would also like to take this opportunity to introduce and thank Lucia Bosokova, who is part of the River EU team, and she's helping with the translations today. And finally, our last panelist is Salima Ouali. Salima is a master's student in medicine at the University of Groningen with minors in global development studies in Moroccan culture and society. She is experienced and committed to improving health care of underserved communities, particularly within reproductive and sexual health. And she is currently active in the River EU project as a health promoter and research assistant. So thank you to all of our panelists. So I would like to start actually in Poland with the Ukrainian migrants. So I would like to ask Mufida. Ukrainian migrants in Poland are very mobile people. They move for work, they move between countries, and since the full-scale invasion in 2022, those who arrived had fled in an emergency, often with children or alone, carrying everything that comes with that. How did that change what you and your center had to do?
First of all, I want to thank the project for giving a chance to the people. First of all, I want to thank to River EU for giving a chance to the people, to the various countries who don't have access to the vaccine, give them the chance to get vaccine. First of all, I want to thank the project. And after 1 week in Poland, we opened a clinic special for Ukrainian refugees. There was working doctors who speak English, who speak Ukrainian, who speak Polish. There was Ukrainian doctors who finished university in Poland. And first of all, we opened the clinic and there was the people from Ukraine, they came to the doctor who speak same language. And we start to help them. First, we have also shelter for helping the refugees. And then after that, we open a clinic for them. They came there, they speak in their own language, they asking what they need. And we was take care about all of them.
Okay. Usually, vaccination is not the first thing on someone's mind when they've just fled a war. Usually they're thinking about their own personal security. Yeah. So how did you create the conditions for that conversation? And how did you earn the right to even bring it up during such a sensitive time?
First of all, we was talking about how the person feel. How they are feeling in Poland, because they was rushed, they was stressed, they even don't know what would be the next. They was all in a big stress. But being honest, we first take care about them after about vaccination. We told them we was thinking how to protect them, how to help them, and then after we tell them that we have a vaccine, and as we know, according to the Polish regulation, everyone the schools, the after schools, we need to be vaccinated. And then we start to work with the project. There was a there was, after I think when we start to work in the project, there was coming a lot of doctors who get their documents and they was allowed to work in Poland. And there was a doctors who already know these patients and they trust them. And then we was telling them that we have such kind of vaccine. And as I want to mention also that there is there's no, in Ukraine, HPV vaccine is not so popular. Everyone know that. And it's so expensive. We already know that. They were so happy, really. They were so happy that they have for free vaccine and their daughters, their sons could get vaccine until 40 years old for free. And they was asking, like everyone asking me, being honest, people from Asia and Mid-Eastern, they don't know what is vaccine. And our role as a medicals to tell them what is this, why they have to get vaccine. And then when we trained them, they was trusting us and they was coming to us to clinic and they was getting vaccine. There was all the parts.
Thank you. Can you share with us maybe a moment or a person or a conversation that for you really captures what this work was about?
Oh, I remember, like, I was talking with a lot of peoples, a lot of refugees, and but one of the problem was there was coming a lady from near Kiev. She came from her 3 daughters, and she was so rushed. She don't even know that what would be the next on her life. She was scared. She was telling me, like, I don't know what to do. And I was thinking, oh my God, this is a lady. She don't know what to do. Then what the kids would think. It's really what's heartbroken. And then after we was telling her, like, we have a shelter. She stayed with her kids on shelter 1 week. And then we was taking caring about her kids. And then after 1 week, she was heard about our project. She came to the meeting, what we did every week on Sundays. And they suddenly come in. She was like, I want to vaccine my kids. I was like, and she being honest, what I like in even there was a word the dads and mom, or the moms actually, they came and they asked, what is this? Which kind of vaccine is this? Can you tell me what would be next? Why we have to vaccine our kids? And our role was telling them how important is this, like how important is vaccine your son and your daughter. And most of all, we telling, like, there was a lot of daughters, like the husband was in a war, and we telling them that why it's important to get a vaccine, especially for the girls. And she was like, yes, no problem, I will come. And all her 3 daughters came to our clinic. They got 3 dolls till today. They're coming to our hospital. And as I know, we have in Poland now, in a clinic where we're working, we have 7,000 patients. And from the 7,000 patients are 3,000 kids. And from them are half of them, even more than half of them, are vaccinated until today.
Well, thank you very much for sharing. That really is such a great story, and it captures the importance and the impact that River EU has had on the community. So we've heard experiences from implementation in a clinical setting, and I'd like to move on to another setting, which in some contexts is more unconventional for vaccinations, and that is schools. Greece was the only country that actually implemented a school-based component because it was the only country where school was simultaneously the most reliable way to reach a highly mobile, dispersed migrant population, and where the community itself expressed trust in schools as an institution. So, Daphne, I would like to start by asking you, the intervention in Greece happened in your school with migrant and refugee children, many of them from Afghanistan and Syria. What do you remember? Was there a moment during the implementation of River EU with a student, a parent, or a teacher that has really stayed with you?
Thank you. First of all, I would like to thank the consortium and everyone for being here. I'm very honored. My only relationship with medical world is that I look at the internet to find how I will live longer. So it is quite interesting to be among you. What stands out really in the school is how much trust had to be built before anything else could be done. Many of the children came from immigrant and refugee backgrounds, from Afghanistan, Syria, Iran, but really from 25 different countries. And so they face extreme poverty, they face very bad living conditions. So their families often carry experiences of instability, of difficult health care systems, being on the road for so long. So one moment that really stayed with me was during a meeting with a single father from Iran who at the beginning was very hesitant about vaccination. Through the support of the cultural mediators, but also the very important work that Prolipsis done with the intervention, and this respectful discussions, the fathers gradually opened up, not just about vaccines, but about past experiences and fears. It was it was a very important moment. It was a conversation that changed things. The feeling that he was able to speak, he was listened, he was heard. The moment made me realize that the project was not only about vaccines. It was about trust, it was about dignity, it was about hope, communication, but most of all, inclusion.
Thank you. Parents in your community were often the ones making vaccination decisions. Did you notice any change in how they engaged with the school around this topic? And did conversations happen that wouldn't have happened before River EU?
Yes, there are things that happen in the school that you cannot really measure in numbers. There is a shift over time for things that at the beginning we could not even speak about. And now we are in the position not only to receive them in open conversation, but also give advice as far as we can, of course, because we're not professionals. There was hesitation, sometimes silence. As the project proceeded, conversation became more open and frequent, and parents started approaching us and asking for help. What is very important to say is that after some time, after they've heard that the intervention was going on, they came back and asked for more. Of course, this could not happen. Maybe you know that it's very difficult to bring parents at school, especially at the age over 14, 15 years of age, because parents think, I've done with you, go to your school and forget about you. But they keep coming back because they felt that it was a space, it was safe for them. And even yesterday, before I came here, a mother came and said, look, you have to excuse my daughter because I will get them to do the cancer vaccination. That was how they realized. They're afraid to say that it is a vaccine related to sex, but it is easier for them to say that it is a cancer vaccination.
You're running a very intercultural school, and this is very complex. What did it mean to add this kind of health work into that space? And did you feel like it was a natural fit, or did it create more tension?
It was challenging, but also meaningful. On one hand, it added a layer of responsibility for teachers and staff who already have difficulties navigating through linguistic and cultural and social diversity. At times, it did create tension, even among the staff, among the teachers, especially when dealing with sensitive topics like vaccination, where beliefs, fears, and misinformation is deeply rooted. However, in many ways, it also felt like a natural extension of the school's role. Schools are not only places for learning, but also key community hubs. Supporting students also means supporting their families. Over time, this initiative helped strengthen the relationship between the school and the community, making the school a place not just for education, but also of support and trust, and most of all, about inclusion. I have to stress that.
Thank you for sharing your insights. They're very important. So what we've heard from Greece is a story about reaching a community through the institution of schools that already held their trust. I want to stay with this idea of trust, but move to a very different context. In Slovakia, River EU worked with marginalized Roma communities in the Košice region. These communities experienced some of the deepest health inequities in Europe, where relationships with health institutions are often shaped by discrimination and mistrust. So the entry point there couldn't have been a school or a clinic. It was an existing national program called Healthy Communities, run by an organization called Healthy Regions, a body under the Slovak Ministry of Health. Overall, this project has a history of more than 20 years, of which 10 years have been operating under the state. That program has built a network of more than 320 Roma health mediators, of which 3/4 are women, who live and work directly inside marginalized Roma communities. These are people from within those communities, trained in health, whose job it is to be the bridge between the community and the health system. River EU tapped into this existing resource, and it asked those mediators to take on something new, HPV vaccination. Mr. František here is with us. He's the coordinator of the Roma Health Mediators, and I would like to ask him, who are Roma Health Mediators, and what does their typical workday look like?
Takže prvá otázka je, kto sú vlastne mediátori zdravia, čo je ich typický deň, čo vlastne zahrňa ich práca.
Pozdravujem. V prvom rade sa chcem tu poďakovať, že môžem tu byť a že môžem sa podeliť o tú radosť, že mohol som byť súčasťou toho programu River, kde našim ľuďom, našim klientom veľmi pomohlo v našich lokalitách.
First of all, I would like to thank for the opportunity to be here and to be a part of this project, and I'm very glad that this project really helped to people living in our communities.
Asistenti podpory zdravia sú časťou komunít. Žijú priamo v lokalite, sú takou spojkou medzi klientom a tým našim lekárom. Takisto sprevádzajú ich systémom zdravotnej starostlivosti.
Healthy mediators are people who are directly living in the communities, living and working in the communities, and serves and acts as a bridge between the healthcare professionals and people living in the communities.
V tej komunite prinášajú dôveru, takisto často prichádzajú len so základným vzdelaním a v organizácii sa pravidelne vzdelávajú, aby dokázali pomáhať tým preventívnymi opatreniami.
So they typically do not have any formal education, but became educated within the organization to be able to help people living in the communities.
V spolupráci s lekármi, ako sú činnosti meranie krvného tlaku, sprevádzanie na vyšetrenia daných klientov, alebo či to osvetohľadom očkovania a preventívnych prehľadok. To je všetko ich naplní práci.
So their work is typically field work, and they rarely sit behind the desk in the office, and it typically means door-to-door, face-to-face daily meetings with clients and healthcare professionals. And it includes, above all, monitoring of health in community, addressing health issues such as measuring blood pressure, provision of medicaments, supervision of medication use, monitoring of patients' adherence, but also inviting people to regular checkups, to mandatory vaccination appointments, and also during outbreaks and epidemics, they serve as a support for public health authorities and healthcare professionals.
Pracovný deň asistenta podpory zdravia je terén. Oni sú súčasťou, by som povedal, ich života.
So the typical day is really in the field, and they are part of the community. They are living there, so they really provide low threshold help, provided continuously 24/7.
Ďakujem.
Thank you.
Thank you. Within River EU, you were trained on HPV and then went out to talk to parents and young people about it. We know that HPV is not an easy topic in communities. It's connected to sexuality, to the body, to things that aren't always spoken about openly and are often sensitive. What was it like to have those conversations with people you know?
Takže v rámci projektu River si absolvoval aj ty školenie o HPV, o ktorom si sa potom išiel rozprávať vlastne s rodičmi a s mladými ľuďmi. HPV nie je v žiadnej komunite vlastne jednoduchá téma, pretože je spojená so sexualitou, s vecami, o ktorých sa nevždy hovorí otvorene. Aké to bolo viesť pre teba a pre ostatných tieto rozhovory s ľuďmi, ktorých poznáš?
Téma HPV je v našich komunitách veľmi citlivá, pretože je spojená so sexualitou a reprodukčným zdravím. O takýchto témach sa často otvorene nerozpráva, preto bolo dôležité pristupovať k ľuďom s rešpektom, s citlivosťou a hlavne s dôverou.
So the topic of HPV is generally very sensitive in our communities because it is connected to sexuality and reproductive health. We do not typically speak openly about such topics. That's why it was very important to approach people with respect, sensitivity, and above all with the trust.
Na začiatku nebolo jednoducho hovoriť o intimných témach, ako sú pohlavné prenosné ochorenia alebo prevencia rakoviny. Postupne sme však zistili, že ľudia sú otvorenejší vtedy, keď sa s nimi niekto rozpráva, ako ho poznajú a komu dôverujú.
At the beginning, it wasn't easy to speak about such intimate topics, such as sexually transmitted diseases or the cancer prevention. We gradually, however, found out that people are more open when they speak to someone they know and trust, and that is why it was a huge advantage of the health mediators who directly live and work in communities.
A práve preto to bola veľká výhoda asistentov podpory zdravia, ktorí pôsobia priamo v lokalitách.
As I said, it was an advantage of health mediators who knows all the people living in the communities personally.
Najskôr sme viedli také informatívne osvety a ľudí sme zároveň povzbudzovali, aby sa v prípade obratili aj na lekárov.
So at first we were focused on information awareness campaigns, but we also encouraged people to ask also GPs, doctors and pediatricians in case they have any further questions.
Čo je veľmi dôležité, je poznať tú komunitu. Vedieť, ako s nimi rozprávať, komunikovať s tými ľuďmi a aký prístup zvoliť. Každý človek reaguje inak, a pri takej citlivej téme je dôvera, by som povedal, taký úplný základ.
The fundamental is to know the community because each community is completely different, and it is important to know how to communicate with the people in particular community and which approach to choose because each person reacts differently, and in such a sensitive topics the trust is absolutely fundamental.
You received training for this, but I imagine the training didn't really prepare you for every reaction that you received. Can you share with us something maybe a community member said to you that you didn't really have an answer for? And can you describe a bit about what you did to deal with this situation?
Čiže získal si na to školenie, ale predpokladám, že školenie ťa nepripravilo na všetky situácie vlastne v teréne, na každú situáciu. Stalo sa niečo také v komunite, alebo bolo ti povedané niečo také, na čo si nemal odpoveď a čo si vlastne v takom prípade urobil?
Samozrejme, objavili sa aj otázky, na ktoré sme v danej chvíli nepoznali odpoveď. Myslím si však, že je dôležité vedieť si priznať, že keď niečo nevieme, nesnažiť sa ľudu dávať neoverené informácie.
Of course, there appeared also questions to which we were not prepared and we did not know any answer at that moment, but I think that it is very important to admit that we do not know and not to pretend that we know everything, and rather than to provide unverified and incorrect information.
V takýchto prípadoch sme ľudí odporúčili na odborníkov, najmä na tých našich pediatrov alebo lekárov v našom regióne. A často som si zároveň informácie aj sám dostatočne naštudoval, aby sme mohli ďalšie osvety viesť kvalitnejšie a vedeli reagovať na otázky v tej komunite presnejšie a zrozumiteľne.
So in such a cases that we did not know correct answer, we referred people from communities to healthcare professionals, especially to pediatrics and GPs and doctors in our region. And I also tried to further educate myself in this question, so it was kind of like an interactive process to ameliorate and to increase the quality of the awareness campaigns and to be prepared to react for such a question in community more accurately and understandable.
Taktiež tento projekt nám ukázal, že úlohou mediátora nie je všetko vedieť, ale správne nasmerovať a budovať dôveru medzi komunitou a zdravotníckym systémom. Bez dôvery sa to nedá.
What this project really taught us was that it's not our role as a health mediators to know everything, but to know how to guide and direct people in a good direction and to build trust between the community and the healthcare system.
Thank you. What Mr. Turták just described is a formalized community network that exists because the Slovak government recognized that the health system alone couldn't reach Roma communities and created an official role to bridge this gap. In the Netherlands, there was no equivalent structure. The Turkish and Moroccan communities River EU wanted to reach are long settled, second generation, and in many cases, they know the health system exists and they know they can access it. But something was still getting lost between the system and the community, and a new structure was needed. Salima is a medical student from that community, working as a health promoter out of Jasmijn Cultural Center in the Netherlands. And Salima, I would like to start by asking you if you could explain on what collaboration was initiated and built in the Netherlands, and what is your experience with how you reached community members?
Yes, thank you. Before I start, I would like to thank you for this opportunity to not only talk about my experiences, but also to represent the other health promoters in the Netherlands and also represent my community within the Netherlands. So, as you said before, in the Netherlands, we did not have a formal structure we could rely on. So, to reach the community and to recruit them, we had to build our own network. And this collaboration started when Janine contacted Jasmijn's Women's Cultural Center. And this is where I have been an active volunteer for years, so that's how I came into the picture. To give a very short description, Jasmijn Cultural Center is a women's center run by and for women, so they have a very extensive network within the community, so also with Moroccan and Turkish women. So we did not completely start from zero. We built upon this network that Jasmijn already had. So to give an example, Jasmijn has several groups, and one of them is a group that regularly come together. They have educational sessions on certain issues, such as, for example, breast cancer screening. And we joined one of these sessions and then gave our educational session on the HPV vaccine. And this gave us two benefits. So one of them being that we already had a basis to build upon. So already a group with a few participants that we could then recruit extra women to join. But also, and the biggest benefit of this was it gave us a space that women were already familiar with and that they already trusted. But still, there was a very big challenge. I think, in my opinion, the biggest challenge is to recruit the additional women to join these sessions, because in the Netherlands, the Turkish and Moroccan community, they already know how to access healthcare system. They probably have already received the formal government letters at home. but still we see discrepancy in the vaccination rates. So how do you then convince these women to still show up to our sessions? And how we did this in the community is we use channels that we use a lot in Jasmijn as well. These are channels that we know work very well within the community, which are mostly through flyers, word of mouth, WhatsApp groups, and just personal invitations. And these channels are not accessible to government organizations or healthcare systems, but as someone from the community, I could easily access them. And I think that's the key lesson in how we built the network, is that we used tools that already exist within the community. We used tools that they already naturally use to communicate and how they already naturally gather. And I think that's very important in order to reach a community that up until now wasn't very reachable.
One of the things River EU found consistently across countries is that when someone from the community itself carries the message about vaccination, like you were saying, something shifts. Trust builds differently than when an outsider arrives with the same message. You were sitting a lot of times with families from your own community or with whom you shared a background. Can you elaborate if that actually mattered and if being one of them actually changed the conversation, and if so, how?
Yes, I think it made a huge difference in almost every part of the process, from beginning to end. At the beginning, it made a huge difference when I worked with Lama and Janine, and we worked on the presentation slides, which we were going to present to the community, because initially the slides that were made were very data-focused and very medical, and we as health promoters then really gave our input on what the community needs and what information they would like to see. So, for example, we focused on very basic information. What's the vaccine? Why is it important? What's in the vaccine? But we especially emphasized that the community needs a space to ask questions. They really just want a dialogue. So that's first how we set up the space to create trust for the conversations that will happen later. Then, as I mentioned before, the recruitment, you need to have a similar background in order to use the channels to reach the community, but also me inviting them, someone they can relate to, someone they know, that already carries more weight than if someone from the outside would do it. But I think the biggest difference is in the conversation itself. The most common belief, or one of the common beliefs within the Moroccan and Turkish community in the Netherlands regarding HPV is that they believe that they don't need the HPV vaccine for their children now because they're not sexually active before marriage. And this is a very sensitive belief. If someone from the outside immediately tries to correct this belief, people can feel judged, might even feel insulted, and then the conversation stops. But as someone from the same background, I can understand the religious and the cultural context of where this belief comes from. And I could honestly have an honest conversation with them and tell them, I understand where you're coming from, and I understand where the belief is rooted in, but I also know that in reality, it does not completely match up to what they think happens. So parents don't always know what their children will do. You don't know what's going to happen in the future. But this is a very sensitive conversation to have, because you're talking about the children, you're talking about the religion, you're talking about their culture. But I was able to have that conversation because I am from their community. I speak from experience. And having that conversation completely changes the tone, because now, instead of someone from the outside just providing them information, telling them what to do and how to do it, it was someone within the conversation, within the community, listening to them, giving them a space to voice their concerns. And instead of them just being spoken at, they were spoken with. And I think that's also what I received as feedback afterwards. The participants came to me and they told me how much they appreciated that I pointed out this discrepancy that exists within the community, and how much they appreciated that I was able to voice that. But they also mentioned that if someone from outside the community would have directly voiced this, it might have come off insulting. But I was allowed to do it, and that makes a huge difference.
Thank you. That's very important. I know you're a medical student. Has this work changed how you think about the kind of doctor you want to be? And as a future medical doctor, what is your idea on the role doctors should play in the communication on HPV vaccination?
Yes, for sure, it has a huge impact, and I've been thinking about this a lot. I think doctors can play a much more important role in preventive care than they realize now. I'm talking about doctors working in clinics. I think, first of all, as we've seen in River EU, doctors can help out in the field and be in contact with the community and be involved in these educational sessions. For example, in Groningen, they have the e-learning to educate doctors on how to talk about this topic. So that's something they can be involved with directly in the community. But I also think doctors can play a much more important role in the hospital as well, because there is a group of people that we might never reach. There are people that will not show up for the educational sessions, that will not respond to the government letters, so we might never reach them. But the doctor might still reach them, because everyone once in their life will probably sit across the doctor for a consultation or just any health issue. And I think that's the perfect opportunity for a doctor when you're sitting across a patient to bring up this conversation. And we could do it in very normalized way, the same way that when you have a consultation at the doctor and they ask you if you have any allergies, if you use medication, if you smoke, why don't we just also ask if they're vaccinated? I think it should be more normalized conversation to have at the doctors. And I think the worst case scenario is someone says, I don't want to get vaccinated. Then you ask, why don't you want to get vaccinated? And you have a bit more insight in your patient population. Best case scenario is you will able to have a conversation with them, provide them actual medical facts instead of whatever they've heard from other people, and they might decide to vaccinate, and then you've made a difference again. And I think that's something doctors could work on in the clinic.
Thank you. We have heard from each of our panelists about their unique experiences in the field, and each one brings, a different context, a different community, but it's clear that all of the work has really had a huge impact on their community. So I'd like to kind of finalize with a question for each of you. If you could kind of, our project unfortunately has come to an end, so I'd like to hear from you what you think needs to happen next, and what should be the next steps after River EU, and who you feel is responsible in implementing this. So, Mufida, if you can start.
Hello. First of all, we will continue this project, of course. And I want to, we're having now another project. After this project, we would think that we would go forward. And we are working now with medical universities in Ukraine. We are having another project, and this also the same project, but we are also checking if the patient have HPV or not. This is the next project. And also we are, I really want to also tell to our, I am from Asia, and I want to tell to our Asian peoples who don't know what is this, telling them that we are allowed and we can vaccine in Europe without any problems. And I want to also telling everyone, like, it is possible, and you can come, you can vaccine, you can ask. And as a doctor in the future, I want to be, as Salima mentioned it, like as a doctor, you have to ask and you have to propose the people's, like, what is this? Because no one know what is this. Like, not everyone know about information. And we will continue this project and hope we will vaccine more peoples and we can save more women's and everyone. Thank you.
That's great. In Slovakia, how do you plan to move forward?
Myslím si, že je veľmi dôležité pokračovať v osvete a budovaní dôvery medzi komunitami a zdravotníckym systémom. Lekári a pediatri by mali aktívnejšie informovať rodičov o možnostiach očkovania proti HPV. najmä pri deťoch, ktoré spĺňajú vekovú hranicu na bezplatné očkovanie.
I personally believe that it is important to continue in the information awareness campaigns, but I also believe that doctors and pediatricians especially should be much more active in Slovakia in informing parents about the possibilities and opportunities as regards HPV, especially for the children who are eligible for the free vaccination.
Rovnako dôležitá je osveta cez školy, sociálne siete, médiá, ale aj miestne inštitúcie, ako sú obce, komunitné centra. Ľudia potrebujú dostávať zrozumiteľné a dôveryhodné informácie.
I also think that equally important is to educate through schools, social media, regular media, local institutions and authorities such as municipalities and community centers, because I think that people should get understandable and trustworthy information.
A za veľký úspech považujem aj to, že vďaka projektu River sa podarilo zaradiť tému HPV medzi oficiálne intervencie organizácie Zdravé regióny. Asistenti podpory zdravia dnes majú túto tému zahrnutú vo svojej pracovnej naplni a venujú sa jej priamo v komunitách. To znamená, že projekt neskončil a ich diskusia, ale reálne sa zmenil prax v teréne.
I consider as one of the biggest achievements of the River EU project that we have been now included HPV among official interventions under our organization's Healthy Regions, and our health mediators today have this topic included in their regular daily workload, and they continue addressing HPV directly in the communities. It means that project did not end with the discussions, but really changed the practice in the field.
Thank you. Salima, can you elaborate on what's going to happen next in the Netherlands?
In the Netherlands, we're also expanding to a different community that's grown within the Netherlands, which is the Syrian community, because what we've noticed during our educational sessions is that they also really want to learn more about this topic. So that's what we're moving towards too. And I think what needs to be done next is for the Moroccan Turkish community is that we need a permanent long-term structure, because what we've noticed now, and I've talked about this with community members, with other health promoters, is what we see happening is a lot of individual research projects reaching out to the community, to health promoters like me, to be part of the project, such as breast cancer screening, cervical cancer screening, HPV vaccination, which is great. They do great work. But once the project is done, they leave, and that's it. So there is no formal structure, and I think that's what needed to make a real difference. And if you genuinely want to reduce these health inequalities, which are very present within the Moroccan and Turkish community, not just the HPV vaccination rates, you need to have a funded long-term structure that's rooted in the community, such as Jasmijn, where the work of the health promoters is also funded, and that provides educational sessions, not just on this topic, but on other health topics as well. And that's always rooted in one place, so the community knows when it's going to happen, where it will happen, and who it will be done by. And I think that's the best way to ensure continuity, but also sustainability of the project. So that would be my request to people that have a say over what's going to happen next.
Thank you. And last but not least, Daphne, can you tell us what's going to happen in Greece? And who's
Well, nobody knows, but we are ready to share our the good practices with other schools, because for me it is very important to build on what is already done and to try to organize horizontal synergies. Schools sometimes feel that it is something very difficult for them to do, but we are there to share what we have done and how we can expand that. Because, of course, responsibility should be shared. And also, if there is one thing to remember, is that listening is as important as informing. the question for me is not only how do we increase uptake or how do we build the network for more vaccination, but how to build trust. And trust is not built through campaigns, is built through relationships.
That's a very key point. And I want to kind of conclude our session with, first of all, thanking you for sharing your important work that has really had such an important impact on the communities. And it's very interesting to see that regardless of the country, regardless of the population group that you are working with, the importance of trust, regardless of the setting, when you are working with minority and disadvantaged populations and trying to increase vaccine uptake. And we saw that as well with the empowering community that I worked with, the Palestinian Arab minority in Israel, how important trust is. And also the importance of framing the vaccination in a way that is not really associated with religion or with sexual behaviors, but more as, a way to protect health, how important that is. And finally, the need to work, that it's coming from someone within the same community and how much that matters. So again, it's really heartwarming for me to see these interventions that have taken place. I remember 4.5 years ago, starting this project and actually trying to identify and research the health system barriers and enablers to vaccination in minority communities. And it's really important to see, the great impact and the great work that you have done in all of your communities. And I look forward to hearing and following up to see what happens next. So thank you to our panelists, and thank you for inviting us to be part of this and
Thank
for
you.
implementing this important session.
Thank you so much. I really loved everything I heard. I think this session is going to stay with me for a long time. Now I would like to invite you for a well-deserved coffee. And it's going to be 15 minutes, so please be on time. And I would like to also mention that during the coffee break, we'll be displaying some photos from our satellite events. So ahead of this public conference, we asked our country partners to organize these events to go back to communities and stakeholders to show them what their contribution led to and actually thank them. So really closing the loop of research. So please also, while you're sipping your coffee, take a look at it. Thank you. See you soon.